My dad thought it might be useful for me because I guess I'm a doctor to talk about some things that would be useful for patients to know. And I guess today will be one of those talks. So, you may not have known, but doctors are actually more trusting nowadays than ever before. And obviously, I don't mean they're trusting of patients because, haha, doctors still don't trust patients. In fact, they probably trust patients less now than before. Because it doesn't matter what the patient tells you. They could be telling you the least important things, not telling you the most important things, and you're still responsible for figuring out what's going on. But I think the main issue right now is that doctors are more trusting of other doctors. Why is this important? Well, the reason is you better beware of what's actually in your medical chart and what other doctors think about you because it may not be correct. So let me tell you about my training in residency. There's an infamous doctor called Bill Wong, and he taught us something called trust but verify. Now, he doesn't trust other people. He likes to review this stuff himself. And actually, I think that's the better way of doing it. So he gave me an assignment one day. He says, hey, your patient supposedly has atrial fibrillation. Now, this matters because if she does, then she should be on a blood thinner. And blood thinners are a big deal. They're increasing your risk for bleeding. So I want you to figure out whether or not she actually has atrial fibrillation. We do have electronic medical records most places nowadays, so it's not too hard to figure it out. So you have to go through the computer, you type it in, and just look through every single one of her EKGs, because that's how you figure out somebody has atrial fibrillation. It's talking about looking at primary data, right? EKG, looking at their heart rhythm. That's how you diagnose atrial fibrillation. So I went through every single one, and I got to number 25. I said, aha, got it. You know, there's one of them here that shows atrial fibrillation. He says, very good. Now, the second part is, what was the situation? So again, I had to look through, see around that day. Was she in a hospital? Was she in a clinic? Where did they get the EKG? Why did they get it? And lo and behold, she was in the ICU. She had just gotten the operation. And afterwards, he said, what does it look like? And it's like, yeah, afterwards, she was in normal sinus rhythm. Why is this important? Well, yes, the person was somewhat correct when they said she has atrial fibrillation. It's listed in their problem list. It's passed on through all this computer stuff. But the thing is, it's perioperative, post-operative. And actually, if it just converts afterwards, you say that's fine. You're in a lot of stress with your surgery. You had a brief period of atrial fibrillation. You converted briefly afterwards. You're not a higher risk for having a stroke or a clot. So we don't worry about blood thinners. But the only way you could figure it out is you got the primary data. Of course, it'd be nice if people put the exact thing, post-operative atrial fibrillation, but many times it's just something in a computer, right? A phrase, a problem in a list. Doesn't tell you very much. You're not really sure what it is, so you just interpret however you wish, which is wrong. So the reason we don't do that nowadays is it's very time-consuming. So yes, we do have access to all these records, and yes, we have all this data we could look at. We can come up with our own diagnoses, but think about how much time that takes. Wouldn't it be faster to just take this data and just say, oh, somebody already reviewed it? Let me just trust them. Isn't that wonderful? We're so trusting of other people nowadays. Let me tell you another example. So I was in Maine, and if you didn't know, and I didn't either, Maine is actually a very poor state, which I could tell by being in the hospital. So in most hospitals, this is probably 5-7 years ago, most hospitals, they have electronic medical records. Here, they still have paper charts. They do use computers, though. That's called meaningful use, if you've heard of the term. Computers are for putting in orders and checking labs. And guess what? You get to wait in line because they don't have enough computers. I actually ended up buying another monitor for myself just to use it in the office because they had a dinky 15-inch, and who uses 15 inches nowadays? 22 at the minimum, right? I mean, 25, 27, they're pretty common. Bigger screen just helps you see so much more, be more productive. The idea is, though, that over there, even though things take a lot of time, some doctors still put in that time. There was an infectious disease doctor that I admired a lot because this is what she did. So I had a patient who was very ill. In the afternoon, they called me one day, and every hour his temperature kept going up by 1 degree. Like, oh, no bueno. And so he ended up going to the ICU, and afterwards they said, oh, you're so silly, right, sending him to the ICU. He's fine. And they kept him there for a few days. They couldn't figure out what's going on. His blood cultures didn't show any bacteria, so you're like, oh. And then one day he's there, and then the nurse says, hey, the lab called. He has fungus growing in his bloodstream. I said, oh, probably a mistake, an error. But the infectious disease doctor was sitting right there. She's like, no, just treat it for now. Don't worry, I'll take a look. Give me some time. So I put him on some medications for a fungus just to cover in the meantime. And she took a look. And she reported me that afternoon, after taking literally over an hour to comb through all his records. Remember, these are paper charts. And if you think how bad my writing is, well, shouldn't make this generalization. But, there's people called surgeons who write even less than us internal medicine doctors. And their writing's even worse. So she looked through all the surgery notes because he's written on surgery. And it makes sense. This is maybe related. And she said, yeah, the urologist noting that there's this whitish stuff, over the prostate. He just sort of flicked it off. Whitish continency stuff? That's fungus. He's been treated so many times for prostate infections, UTIs, that eventually the bacteria died and the fungus overgrew. So she figured it out. It took her a long time. He would say it's worth it. But the question is, do you always have a doctor like that? So I remember my friend telling me she was in medical school and she had gotten a pretty bad illness, not really sure what it is still to this day, but she got some clots and she was in hospital, and a medical student was there because at university hospitals oftentimes you have medical students who come and interview you. They have to get some practice. So the medical student said, hey, so about this lupus, can you tell me about? And we all know medical students are very interested in things like lupus, because lupus is something that's very well known. We all learn about it in school, but it's not very actually common, so we don't see it very much. And so she got really upset. She's like, take that out. I do not have lupus. So she actually has something called lupus anticoagulant. It sounds like lupus, but it's not lupus. You have a few different criteria to meet the diagnosis of lupus. She doesn't meet the diagnosis of lupus. However, somebody must have written lupus anticoagulant. Somebody copied it, and somehow, like that telephone game where you hear and sort of gets misinterpreted. Somebody wrote down lupus, and yeah, I guess that makes sense. She has all these weird illness symptoms, blah, blah, blah. But it's wrong. And it would make a difference in her life, because if she had lupus listed on her problem list, in the future when doctors see her, they're like, oh yeah, this is related to lupus. They wouldn't say that. They would just be thinking that. And that's wrong, because she doesn't have lupus. It's not related to lupus. You can't treat the lupus and make it get better because she doesn't have lupus in the first place. So you may be wondering, what can you do about it? You're not a doctor, you haven't gone to medical school, and that's absolutely correct. But guess what you have? You have access to your records. Nowadays, you have access to lots and lots of doctors' notes. But say you don't, say your institution's not one of those that has all the things, you could at least get a copy of the major things, like your clinic doctor's notes, history and physical. In a hospital, you have something called a discharge summary where the doctor summarizes it for other people to know in the future. You could take it, for example, if they don't have electronic records, you could take it from the hospital and you present a copy to your PCP, that they have a brief, concise record of all that's going on. And you can look to see, so it says I had a stroke, but I don't remember having a stroke. Did I have a stroke? And then you could ask your PCP about it, and one of two things would happen, and either of those are beneficial. One is, yes, you actually had a stroke. Maybe somebody told you and you're out of it, forgot, didn't understand what's going on, or maybe nobody told you, but yeah, it would be a good thing to know you had a stroke. The second thing is, maybe it's actually wrong and it was miswritten, miscommunicated somehow. Because you all know, if you stay in the hospitals, that you may have one doctor who admits you, another doctor sees you the next day, and another doctor discharges you the third day. Which we all agree is somewhat ridiculous. It's because we work on a shift schedule nowadays. But you would have figured something out. And if you want to make corrections to your medical record, if it's absolutely stone cold wrong, then you can. You could submit a request and they'll correct it. So this is why it's important to realize that doctors are, yes, now more trusting than ever of other doctors. They just take their word at face value. Even though in the past we may have looked into it, now we're all so busy. There's a lot of time constraints and we don't necessarily spend the time looking at that. So there's much more errors that get propagated, especially with electronic medical records. Copy paste, who doesn't use that, right? And so you have an obligation to yourself. You want to make sure you get the best medical care, that you don't have the wrong diagnoses listed on there. And you can make sure, looking through these diagnoses on your discharge summary, they'll have a list of diagnoses, that you understand what it is. Because if it's wrong, then you could actually get it expunged or deleted from your medical record. Because you want to start off with a correct medical record. There's already so much to worry about. This is something you don't want to have to worry about.